We're going to go ahead and get started. I wanted to welcome everyone to tonight's webinar. I am your host and moderator, Dr. Lauren Levine. Welcome, everyone. We've got a great turnout this evening, as always. Well over 800 people registered. As I've been doing for the last year or so, I want to start with making sure that everyone is staying healthy and safe. I know certain parts of the country, like Michigan, are not doing so great. Here in California, we're doing a little bit better. But the need for dental education never goes away, and I certainly commend all of you for being here tonight. I'm only going to speak for a couple of minutes this evening. I want to make sure that Dr. Nazarian can speak for as long as he needs. He also wants to make sure we leave time for questions. Most of you are veterans of these webinars. You know the format, but just to remind you, on your screen you have a GoToWebinar control panel. Type in your questions as you think about them. I don't typically get to the questions until the speaker is done, and I try to get to as many as we possibly can. Some webinars we have 15, 20 questions, some we get 5, some we get 105. I just never know. So I'm going to do my best to get to as many as we possibly can. I want to be respectful of our speaker's time as well as all of your time as well. So we're not going to go much past the bottom of the hour once we get to that point. In the next couple of days, look for a few things. You're going to get an email with a link to download or view the recording. We do record this webinar, so don't worry if you can't make it until the end. No big deal. You can be able to watch the recording at your convenience. That typically comes out within the first couple of days or so. During the webinar this evening, Dr. Nazarian is going to be speaking and demonstrating a number of products that he uses, which are exclusive to Golden Dent. I wanted to thank Golden Dent. I've been working with them for years now to put together these webinars. Anyone that's ever done a webinar knows they don't put themselves together. It takes a lot of effort to get an excellent speaker like we have this evening, to put all the content together, to handle everything afterwards, and I thank them for their ongoing sponsorship. One of the other things that they do is to handle the continuing education. And I'm going to say this a few times this evening because I always get at least half a dozen emails afterwards. When am I getting the CE? What about the CE? The way the CE works is that if you are here and you're on for the bulk of it, and I don't know what exactly that number is, AGD PACE has certain requirements, but as long as you're here for most of the webinar, you will be sent a CE form. It goes out automatically. There's no test to take. There's no quiz. Nothing you need to do on your end other than just check your inbox in the next couple of weeks or so. As you can imagine, when we have 800 plus people registered, it can take a few weeks for that to go out. So please be patient, but they do always go out. And with that out of the way, I am thrilled once again to welcome back Dr. Ara Nazarian. He maintains a private practice in Troy, Michigan. His emphasis is comprehensive and restorative care. He's a diplomat in the ICOI, which is the International Congress of Oral Implantologists. He's an adjunct clinical instructor at University of Detroit Mercy School of Dentistry. If you read dental journals, and you've probably seen his articles, they've been published in many of the popular dental publications. He's consistently listed as a top dental educator. He's conducted many lectures and hands-on workshops on aesthetic materials and dental implants throughout the U.S., Europe, and Asia. He's the lead faculty member for Amplified Dental Training, which teaches atraumatic extractions, grafting, immediate dentures, and all aspects of dental implants. So we got a good one tonight. Ara, we're thrilled to have you back and looking forward to tonight's presentation.
Great. Thank you, Dr. Levine. And welcome everyone to this evening's webinar. Tonight we'll be talking about guided full arch dental implant reconstruction. Our goal when we do these cases is to get consistent results that are effective, efficient, and predictable. And so here's a great example where we took out 32 teeth on this patient. Using guided surgery, we placed 8 implants in the upper arch, 8 implants in the lower arch. So we had implants in all the key positions, and we were able to restore this patient to proper form and function. And when we take a look at the occlusal view, you can see how devastating his dentition was and how we were able to restore him to proper aesthetics and function. So today we know that there's an aging population that's obviously living longer. And according to the literature, age is directly related to every indicator of tooth loss. So as patients mature, sooner or later, they may lose some teeth. It may be a few teeth, it may be several teeth, or it may be the necessity to have all the teeth removed. And there's several reasons for this. It could be their dexterity has been impaired because they've gotten older and they're unable to clean their teeth. It could be because of the medications that have dried their mouths. And so now these teeth are exposed to rampant decay, and several other reasons that we just won't go into this evening. However, we do also have a younger population, and the younger population that we're seeing are also presenting with devastating dentitions. However, they're much more severe than our mature population of patients. And this may be due to some of the different colas that are out there, some of the different energy drinks that we've seen, but also because of some drug use. Methamphetamine is a very inexpensive drug, so it's very available for patients that are addicted to this type of thing. And so it's not uncommon to see in my practice patients that are in their young 30s or in their late 20s that present to the practice and need all their teeth extracted. And so some of these patients, um, because of neglect or because of abuse of these types of different drugs and things like that, um, present, and usually it's the parents that may be paying for restoring their smiles and function and things like that. So we're going to talk a little bit about how we speak to these patients, how we educate them, and how we execute in delivering a full mouth reconstruction. And sometimes it may be fixed, or sometimes if that's over their budget, we may provide overdentures. But our goal is to at least remove these sources of infection from their mouth. Other reasons that may contribute to the need for full mouth reconstruction may be advanced periodontal disease, as seen in this picture, and also some severe cases of bruxism. We see a lot of patients that have presented who may have had orthodontics at a young age where the bites are very constricted, and it may create some issues for them. Obviously, this is not an example of that in this picture. This is periodontal disease with severe bruxism. But these are all different scenarios that contribute to the necessity of having full mouth reconstruction. So in some of these cases, what are you going to recommend? It's imperative to have a variety of different options because not everyone can afford all on 4, all on 6 type of fixed dental implant treatment. So in our practice, we try to offer as many different options to our patients and let them choose according to what fits their budget, what fits their needs, what they want to accomplish, and so on. So the first and most economical option that we offer is complete dentures. The second option may be complete dentures, but the lower denture may be retentive because of small diameter implants or traditional size implants. Usually patients that need dentures or present with dentures, they usually don't complain of the upper denture like they do the lower denture. And the reason for that is the upper denture has some retention and has somewhat of a seal, where in the lower arch, there isn't much of a seal. You also have the tongue that can move the denture around. So in the lower arch, we always try to provide some type of retention utilizing implants, whether they're small diameter, hybrid, which are sort of between small and regular size implants, and then obviously traditional size implants. We may offer overdentures or fixed restorations. In the upper right corner, we see an upper overdenture on locators, and in the lower arch, we see fixed bridges. Or we may provide fixed over fixed, and we try to avoid the sinus cavities. We do this by tilting the most posterior implants. We've all heard of all on 4. We also try to place 6 when possible. So my goal is always to try to put more than 4, but in some cases we do use just 4. So this is a great example of all on 6 or 7. And then obviously we have the most ideal treatment where you may be restoring the patient from second molar to second molar. They may need sinus lifts. The implants are parallel. They're axially placed, so they're straight up and down. And if grafting is necessary, we may do this as a 2-stage procedure. So these are the variety of different options that we provide in our practice, from the most economical to the most expensive, and we'll highlight the pros and cons of each one to our patients and educate them so that they can see what it is that they would like that fits their budget. I can tell you this, 9 out of 10 patients obviously always want some type of fixed. They usually want the option of the tilted implants, fixed on top and bottom. And then when we go over the cost, they may say, well, this is a little bit over my budget and I can't get finance for the whole amount. So let's go with something a little bit more economical. So they may decide to go with an overdenture opposing a fixed bridge. So these are the different types of um, options that we offer our patients. And I think it's imperative to have options for our patients. It's not just one way or the highway. Otherwise, you're going to lose a lot of patients that can be great patients, and you lose the opportunity to be able to help someone out if you're only looking at providing the best option that may not fit their budget. I've been very fortunate in the 25 years that I've been practicing to do a lot of full mouth reconstruction. We've done angled implants, we've done parallel implants, we've done 2-stage and single stage. And the one thing that I found is that the aggressively threaded implants are usually the ones that I like to go with when doing this type of restoration. And today, what we're finding actually is there are a variety of different coatings that we can purchase with these implants. A perfect example is the Addon implant, which we'll be using in our course coming up next week, which is actually already sold out. And we have another course coming up in August. But they provide a surface treatment called OsseoFix. And so this is a biocompatible resorbable material. Essentially, it's a calcium phosphate coating that accelerates the healing process and increases optimal osseointegration. So here's a case that I did literally 2 weeks ago. We took out all the upper and lower teeth. We were able to place the Addon Tourig implants, the OS, which is the OsseoFix. And so once this gingival tissue heals in about half the amount of time of normal healing. So normal healing is usually about 4 months. In about half that amount of time, we can go to the final restorations once the gingival tissue is healed and go to the final restoration. And so we've definitely pushed the limit using this implant from Addon. Notice it's aggressively threaded, and the fact that it has the OsseoFix surface treatment, it enhances and accelerates the healing process. So we'll be showing a variety of different examples of fix this evening. So where do we start if we're going to be providing this type of service for our patients? Well, the first thing I want you to pay attention to is the fact that I've studied a variety of different types of treatment, and I think these are all leaders in full fixed arch treatment. And so what I've done is I've sort of taken a little bit from each one and created my own flavor, so to speak, in types of treatment for fixed arch. So the 3 books that I recommend, number 1 is Contemporary Implant Dentistry from Carl Misch. Dr. Misch was a great mentor to me, and I got my fellowship through the Institute, and that's how I started my career in implants. Giorgio Romanos, which talks about advanced immediate loading and different principles about it. This is also a very good book. And lastly, Edmund Bedrosian. This doctor has a great book on all on 4. He also talks about zygomatic implants. But mainly what I've gotten from this book is the tilted implants or angling implants in the all on 4, all on 6 type treatment. So these are some great books to really add to your implant library for sure. So let's take a look at an example. And this example will talk about extractions, leveling, grafting, immediate implants with fixed teeth or getting fixed provisionals. This patient presented to my practice not happy with her smile. She lost several teeth at an early age, and so she was worried about not having enough bone for dental implants. She wanted to know, she was somewhat apprehensive, so she wanted to know if we can do this all in one treatment and be sedated so that she, would be comfortable during the process. She had recently had some teeth removed, so she was concerned that she may not have healed properly, or there wasn't enough time of healing to pursue implants. So she came in for a consultation. Our consultations are free within the office, but we do charge for the CBCT. In our office, we have the CareStream 8100 3D, and it allows us to get 2D and 3D images. Before we do that, though, we give the patient a tour of the office. We show them what we call the Hall of Fame, which is a bunch of different articles that I've had published in dental journals or in the media. We show them the photo room where we illustrate a variety of different examples of full mouth reconstruction. We also show them the sterilization area, so they see that we sterilize everything and that we're all up to date with some of the technology that we have within our practice. We ask them if they need anything, and then we return them to the lobby and have them fill out paperwork. Just by treating your patients just a little differently than everyone else will put you a step above everyone, and really take their fears away in regards to presenting to a dental office. Once they filled out the paperwork and the information is being inputted into the computer, we'll let them look at a before and after book of my actual patients. We have dates on them so they can see that we've been providing this for over 20 years. Implant therapy, I've been practicing for 25, but implants we've been doing for over 20 years. So what do we look at when they're back in the clinical area? Well, we're going to collect all the data that we talked about, but most importantly, we're going to get an FMX and a Panorex, so we get all our 2D x-rays, but we'll also get our CBCT. We're going to examine the patient and find all the clinical information that's necessary. But in addition to this, I recommend you also take photos. Obviously today everything is digital, so we're able to get digital photos of not only intraoral retracted views, but also extraoral views. This acts as a great tool for communication, not only with the laboratory, but also with the patient. So when these pictures are in the TV screen in each operatory, or in the operatory that the patient's in, I should say, the patient gets a chance to see these, and they may see teeth that are broken down from views they've never seen before, because we usually take an occlusal retracted view as well. And 8 out of 10 times the patient will say, "Are those my teeth?" They don't even believe that it's their teeth, but in fact, it really is. We also take models. If you're taking impressions, you can take actual impressions for models, or you can take virtual impressions with an intraoral device. So it's up to you. And obviously, we already talked about it. We're going to take a CBCT. So these are the usual 4 photos that we capture that pop up on the monitor just like this. It's the full face view, the retracted open bite, and we purposely show the retracted open bite on the monitor, even though we also are capturing patient biting in centric occlusion. And the reason that we go with an open bite is so that the patients can also see the incisal edges. This way, the patient can see if, let's say, there's severe bruxer, the wear that they may have. So it really gives an opportunity for the patient to see from a different aspect what's going on. And then obviously we have the occlusal views of both upper and lower arches. Our goal is to identify, like everyone else, cavities and crazed lines, broken teeth or restorations, bleeding on probing, areas of wear or mobility. And then obviously if we're doing implants, we want to make sure that there's available bone in the areas that are edentulous, or if we need to take these teeth out, where the attached gingiva is, or if they have a partial, are they wearing it? How is the fit? So on and so forth. So here we see the retracted view. Here's the open retracted view, the occlusal view. And so you can see it doesn't look too bad. However, she had lost some teeth very recently. In the lower arch, her treatment is not that severe, or it's not necessary. She just needed some scaling and root planing. So our goal is first to acquire the CBCT. This is the 8100, which allows us to very quickly achieve 2D and 3D images. So here we see the 2D image. Notice in the, let's say 11, 12 area, you can see some fresh sockets, as well as in the 4, 5, possibly even 6 area. Here we have the CBCT using our 8100. When looking at a CBCT, for most of these general dentists that may be listening, usually all CBCTs have 4 different panes or views. You'll have an occlusal view, 2D panoramic view, a cross-sectional view, and then a 2D view, or excuse me, a 3D view. So here we have the 2D, which is the panoramic view, and you can see the fresh extraction sites. Here we have the axial view. Note if we centered on the central area between 8 and 9, so you can see how large the incisive foramen canal is. So this may not be an ideal position for an implant because it's thin. And here we see the 3D view, and you can see the bone in the upper arch is not the most ideal. It may be more like type 2 or type 3. In most of the areas, it was actually type 3 or type 4. And here in the in the axial view, you can also see the areas of extraction. So our options that we offer this patient for treatment in the maxilla include a removable denture, overdenture, all on 4, all on 6, and parallel implants. So we go over the different options, and our patient chooses to go with a fixed bridge. So our goal is to place 4 to 6 implants to get her into a fixed temporary restoration, and then eventually a fixed definitive restoration. So what I usually do is I'll plan it out on my CareStream software, and the software is very easy to use. So here I'm planning the positioning of 6 dental implants in the key positions. And so if we take a look at where we're trying to plan for when we're looking at the positioning of these, is the 3 different zones of bone. We have zone 1 and 2 and 3. Zone 1 is in the anterior area, anterior to the canine positions, or canine to canine, let's say. Zone 2 is in the premolar position, and zone 3 is in the first molar position. Usually we're able to get bone in zones 1 and 2. And so usually our treatment that we offer our patients that are presenting with several teeth missing is all on 6 or all on 4. If they have bone in zones 1, 2, and 3, in other words, they have enough bone from central all the way to the first molar, then there's no need to angle the implants. And so we'll place parallel implants, or what we call axially placed implants. So this schematic really illustrates the different positions of, or zones, I should say, of bone of where we place our implants. I would say 90% of the cases that we do that are all on 4 or all on 6 are going to be in zones 1 and 2. And that's just because of the people that are presenting, that's where their bone is. Now, if somebody is deficient and they only have bone in zone 1, then we may refer them out for zygomatic implants. And if there's totally insufficient bone, then it may be quad zygoma. So these are two areas that I would definitely refer out, and I've partnered with some specialists to be able to offer that for our patients. The nice thing of tilting implants, because remember we talked about most patients only having bone usually in zones 1 and 2, is the use of tilted implants. Tilted implants help us avoid implants in the posterior region, and it allows us to avoid the sinus cavity. Usually I'm going up to about 30 degrees in our tilt for the posterior implants, and usually it's coming out in the second premolar or angling it hopefully to the first molar region. We'll use a cantilever if needed, and usually it's only a tooth or about a tooth and a half of a cantilever, but it also depends on the patient. If the patient's 300 pounds, 6'4", and has huge masseters, then we may opt to go with maybe using pterygoid implants in conjunction with the all-on-4 or all-on-6. The beauty of the tilted implants is that it allows us to provide immediate functional temporaries. Now, when I say functional temporaries, it's a limited function. We don't want them biting into hard food and things like that, but it's still better than immediate dentures. And obviously, we're going to reduce bone if necessary, and we'll show examples of this. So if we take a look at this patient, this implant's about a 3.3 or a 3.5 in diameter, and you can see it's getting pretty tight. So if we do place implants here, we may spread the bone a little bit with osteotomes. So once the patient has decided that they're going to go through with treatment, our goal is to have a records appointment. At the records appointment, they will go ahead and pay for the treatment to reserve the appointment, the block of time to do their surgery. And at that time, we'll continue with more photos, measurements. We'll take a look at the transition line and the lip line. We'll achieve a bite as shown here, but also we'll take upper and lower molds. Now you can do this with impressions, or you can do it with intraoral impressions if you have an intraoral scanner. So you can achieve this either way, whatever you're comfortable with. The other thing that I'll do is use this checklist, and in this checklist, I'll mark different things so that I can communicate appropriately with the dental lab. In other words, here I'm talking about the horizontal plane, the anterior tooth display. Is the midline on or off? You can see it's off about a 1.5 millimeters, so we're telling them to correct that and move it to the patient's left. We're talking about keeping the incisal edge of the new teeth around the number 8 length. So here you can see we're communicating with our laboratory. The last thing you want to do is just say, okay, make an immediate upper denture that I'm going to be using for a conversion for an all-on-4. You have to communicate to the lab, and they have to see photos if you want to be consistent and have predictable results in your aesthetics. This is the form that we use with Arrowhead Dental Lab that does the immediate denture or the FP3 restorations, and you can see some of the instructions I've indicated on there. Now, once we've acquired our CBCT and I've sort of planned it out, I will forward this to 3D Diagnostics or 3DDX, as they're known for. And so what they've done is they've converted that information into their co-diagnostic software. And so we'll set up a WebRx meeting with one of their doctors on staff. So this is one of the technicians who answers the phone, downloads the images and the CBCT, and then sets up an appointment for you to review this with one of the doctors on staff. One of the doctors on staff then will plan where the placement of the pins will be and ask you what type of guide you would like, whether it's a bone seating guide, a bone leveling guide, a tooth position guide. There's a variety of different options if you look at their website at 3ddx.com. And so take a look at the bone in the 4, 5, 6 area. It's not the most ideal as seen in this 3D image. So we're obviously going to be doing some grafting. And so we're selectively picking positions that are in more ideal bone or angling our implants to engage some cortical bone. So day of surgery, we anesthetize the patient. Patient is sedated. We have everything ready. Here's the grafting kit from Golden Dent, which has everything from retracting the gingival tissue to smoothing and leveling bone to packing bone and suturing. So this is what a day of surgery looks like in my practice. Here we're using the wedge to slightly loosen the teeth before we engage the physics forceps. The wedge is a great instrument. I helped develop this for Golden Dent. It's the perfect pre-step in your atraumatic extraction process, and it works very well. If you get a chance, take a look at their website to see how that works. You can see the splinted crowns popped off right away. Here we've made our incision. We're reflecting the gingival tissue with the reflector. This is sort of the beaver tail portion of a molt that we put on a larger handle. And so literally I can reflect a flap very quickly using this instrument. So this is also another one from Golden Dent that works very, very well. Notice there have a titanium nitride coating the blue. So what that does is it strengthens the metal and it keeps its sharpness. Here we're utilizing the physics forceps. This is an upper anterior physics forceps. The set comes in a variety of different forceps. You have your upper anterior, your upper right, and your upper left. And then you have a lower universal that's used for all the teeth in the lower arch. This works very well because it uses biomechanics to selectively take the tooth out in the path of least resistance. So when I was researching this many, many years ago, I found this definition of the ideal tooth extraction. And the definition is the painless removal of the whole tooth or root with minimal trauma to the investing tissues so that the wound heals without compromise and no post-op prosthetic problem is created. I thought about this and I said, wow, this is what I'm thinking about every time I extract a tooth. To take it out without pain, to get it out without traumatizing the surrounding tissue or teeth, and to do it in such a way that the area heals without compromise and no pain. And so the physics forceps is something that I've been using over 15 years now, and something that I've been teaching for about 13 years. And we also have our live courses will be opening up in the fall again, and I'm sure Kurt will talk about that at the end of the webinar. But literally, the physics forceps works like a modified class 1 lever to remove the tooth. So what makes more sense? Excuse me. In this example, obviously, what makes more sense? And using a leverage action like this hammer here in this example is what usually is the most ideal situation. So as Archimedes has mentioned, give me a place to stand and a lever long enough and I will move the world. So there's something to be said about a lever action, whether it's used in lifting things or whether it's used in removing teeth. So when we utilize the physics forceps, our goal is to engage the beak on solid tooth structure, position the bumper as high up into vestibular area as possible. You don't want to squeeze hard, but you're literally going to rotate. You're not going to go back and forth. You're going to put consistent pressure, and usually within 30 to 40 seconds, the tooth loosens, and then we'll go ahead and remove it with either traditional forceps or sometimes even gauze. So here you can see we atraumatically extracted the teeth. Notice the buccal plates on all these anterior teeth, which was very thin, is not broken. Although sometimes you can break it, it's not the end of the world. But utilizing the physics forceps, we found that we have much less facial fractures of the buccal plate as seen in this photo. We're reflecting it further with the reflector. And here's a great occlusal view illustrating how resorbed some of the areas of the ridges. So this is not a very easy case. However, utilizing a surgical guide, we're going to place the implants in the most ideal positions. So this is the surgical guide from 3DDX. You can see we're placing the implants. Notice in the upper premolar area where we've placed grafting material. So we're going to go ahead and suture this up. Using our denture, we're going to go ahead and do a conversion. The Futar bite registration is the material of choice for any type of bite that you may be taking, but also it sets very quickly within 30 to 40 seconds when identifying the areas of where you're going to relieve for a conversion. And so here we're going to open the holes up. Tokiyama is a great material. Now they have Tokiyama Rebase 3, which works even better than the Rebase 2. We use this on our hands-on course. So for those of you who may be attending, you'll get a chance to use this. I know sometimes people prefer to have material that's expressed from a syringe. However, those can get very costly and you go through them very quickly. So what I usually do is use this powder liquid, place it into a monojet syringe and extrude it. And this is probably 1/10 the price of some of the materials that come out of a dual syringe. Here you can see we've used the rubber dam to prevent any acrylic from getting into the extraction sites. And this is the patient's 1 week post-op photo. You can see she's looking great, very little swelling. Here we have her Panorex post-op. You can see the position of all the implants. We've had 6 implants. So here's her before and after. This is what it looks like about 4 to 6 weeks afterwards. You can see a little bit of recession in those areas. This is one of the reasons why I don't go to a final restoration immediately when doing these cases, because you never know when where the gingival tissue is going to heal. A lot of times dental providers will just make a modified ridge lap. However, that sometimes can cause food to get entrapped underneath the restoration. So here we see the before and after Panorex. We're going to allow this to heal for 4 months. In 4 months, we're going to go ahead and take an impression. Here we're using the Kettenbach material. This is called Panasil. Notice we have a custom tray. And so here we have the final monolithic restoration. And here we can see her final restoration torqued into place. So our goal is to have a treatment plan that we can deliver predictably, efficiently, and effectively. And by using guided surgery, we're able to do this. Years ago, I was doing this freehand, and you can still do that freehand. Some people will say they'll save on costs by not having surgical guides, but this really allows me to move much quicker and more predictably when using a surgical guide, especially in some of these tougher cases. So here we see her upper before, and then we see the definitive restoration screwed into place. Obviously, we went ahead and whitened her lower teeth. And so we had done the scaling and root planing in her lower arch also while she was sedated. And obviously, she wanted to whiten her teeth, so we threw that in to try to match the upper as much as possible. Let's take a look at another example. This patient presented not pleased with the appearance of his teeth as well. He is opening a business, so he's going to be doing some marketing and some TV commercials and things of that nature. So he wants to have everything done, and he wants to have the finals within the 4-month period, not only because he's going to be marketing his business, but also he had a wedding to attend. So he didn't want to attend with the dentition that he currently has. Again, we acquired all the images that we talked about earlier, where we have the retracted view and the occlusal views and the facial shots. So here we're going to identify where the midline is. These are, again, some photos that I use to communicate appropriately to the dental laboratory. Otherwise, if you said just make an immediate denture, they're going to follow the same midline and it's going to be off. If we take a closer look, let's just imagine we're going to keep the anterior 4 teeth and do posterior implants. you can see that there's hardly any room for any crowns on implants. So prosthetically speaking, we need to extract all these teeth. Otherwise, we're going to have to open his bite tremendously that it, it would not be very functional. So if we take a look at these different views, one can see why we pursued full mouth reconstruction in doing an upper and lower arch. Again, this patient presented um, talking about how he had teeth root canaled and crowned, but he was informed that he had a high caries rate, and we can see that. And so he had made the determination that he finally would like to undergo full mouth reconstruction. While he was going to be sedated and while we're taking the teeth out, I also talked about his mandibular tori, and he said, yeah, they're starting to bother me. So if we can take those out, if you can do that as well, that would be great. And I said, yeah, that's not a problem. So here we see the right lateral view. Again, you see very little clearance if you were just to do single implants. Again, you see the hypereruption of number 14 and 15. And you see the very little clearance that this patient has in the other regions. Again, the first thing we're going to do is acquire CBCT. We also always get a 2D X-ray as well, so we'll acquire both. This is the 2D, this is the 3D, and so this is what I've planned out with my CareStream software. We'll go ahead and forward that to 3DDX to one of the technicians, and they'll forward it to the doctors on staff, and the doctors on staff will look at my treatment plan and put it into the co-diagnostic software. If you don't have a software that, or you don't have the time to plan it out, they can plan it and do all that for you. And then at the WebRx meeting with them, you'll review it with one of the doctors on staff. Excuse me. Also, you can see where they've indicated where we'll be leveling the bone as well. So we've taken our impressions, pre-op impressions, so they can go to the guides. Here you can see we have not only the guides, but we also have jigs in the orientation of where we'll be placing the implants in the multi-units, the bone leveling guide, and then the final PMMA provisional restorations. So everything is already laid out for us. We'll put that through cold sterilization. So here we have what we call the bone leveling or foundation guide. Then once we've leveled the bone, we'll place the surgical guide and snap that in. We'll drill through that and place the implants. Then we'll position and orient our implants so that the flat is going out towards the facial. And then we'll place our PMMA provisionals by retrofitting these. In the lower arch, again, we have our bone leveling guide, surgical guide that snaps on once we've leveled the bone. Then we have our abutment orientation guide, and then obviously our lower PMMA restoration. So this is what we have for delivery. We always will have a backup immediate upper and lower denture if for some reason we didn't get immediate fixation or stability of the implants. But again, using aggressively threaded implants, as I mentioned, the Edding is a great implant. It's aggressively threaded, and the fact that it's got the OsseoFix surface treatment, it helps to go to final restorations very quick. But as mentioned, as a backup, I always will have an immediate upper and lower denture. So a day of surgery, we anesthetize the patient. We're going to utilize our physics forceps to atraumatically extract the teeth. Once the teeth have been extracted, I'm going to reflect a flap. We reflect the flap and place our bone leveling guide. We position the bone leveling guide with the retention pins. I'll go ahead and use the osseous cleaning and shaping burrs from Golden Dent. This not only has leveling burrs, but it also has cleaning burrs to remove any granulation tissue you may have within the sockets. Many times I've seen doctors just take the teeth out and start placing implants in, and they don't curette the socket out or remove any granulation tissue, and that's going to create a potential future issue. So we want to make sure we clean out and remove any granulation tissue. Here you can see we're leveling the bone. We've leveled it to the bone leveling guide position. Once we've leveled it accurately, And appropriately, we can put in our surgical guide. So this snaps in with those two sort of plastic snaps on the facial aspect. And then once we've done our drilling protocol, we'll place our implants through the guide. So not only do we have depth, but we have angulation and timing when using these surgical guides from 3DDX. Here we can see the position of the 6 implants. We'll make sure our abutment orientation guide is snapped in so that we know where to position our abutments. This is what it looks like. We'll place our temporary cylinders. Now it's time for us to place our temporary. If you notice, there's a silicone gasket so that we don't have acrylic go into the extraction sites or around the implants. So you can see there's no way for acrylic to go past that. We'll block these out. Now I'm starting to use more light body impression material within the holes of the temporary cylinders. And if they do get covered, I just remove it with a burr and then I pluck the light body material out. So I'm not using the little sticks anymore. Again, we use the Tokiyama Rebase 2. Now we're using the Rebase 3. This is an older case. And so this is what it looks like. And then we'll go ahead, remove it and add where necessary, and then polish this up for insertion. So we don't want any voids. In the meantime, we'll go ahead and graft the area. So I always prefer to graft in the areas between the implants or around the implants. Here's the grafting material from Golden Dent, very good particulate graft. And in the areas of the second molars, instead of placing graft, I like to use BioViva. This is a hemostatic wound dressing. It's made of cellulose, and it's a hemostatic agent within it that stops the bleeding really nicely. And so these are very inexpensive. I usually will use these also when I'm taking wisdom teeth out. Here we see the lower arch. So again, remember, this is all in one seating. We've completed the top, and so now we're going to start on the bottom. We anesthetize the patient, start extracting the teeth utilizing the physics forceps. We've extracted everything and reflective flap. Now we position our bone leveling guide. This shows you the accuracy of the CBCT and the accuracy of the surgical guide. Notice the area of the mandibular tori. So this surgical guide went and fit perfectly around those mandibular tori. So our goal now is to level the bone to the area indicated. And so you can see why I wouldn't leave those tori, because they're going to be very sharp if I pop this off and leave that shelf. So obviously after I place the implants and when I remove this bone leveling guide, I will go ahead and smooth the lingual portion and remove those tori. So we place our surgical guide, place the implants, orient them appropriately, and place the abutments, place our temporary cylinders, retrofit the temporary restoration, go ahead and fill in the voids outside of the mouth. While one of my assistants is doing that, I'm going ahead and continuing with the placement of grafting material between the implants or in any other sockets. And notice we've removed the tori. So this is what it looks like while my assistant is finishing up the temporaries. Notice the white caps are just temporary caps. We'll remove those, and that's just so that bone doesn't get within the multi-unit abutments. So here we're going to polish off the provisional restorations. This is what the provisional looks like about a week later. Notice in the 12-13 area or 13-14 area, the temporary stuck out a little bit, so we went ahead and made a couple adjustments, as you can see. And so in one visit, we were able to go from extractions, leveling, grafting, implant placement to fixed provisionals. Again, I was able to do this because of the surgical guides. And so 4 months later, when it was time for impressions, we saw that he could afford to go with larger teeth, and he agreed. So again, just because the temporary is one way doesn't mean he's locked into that. So we're going to go ahead and measure, see what we can do, and do a wax try-in once we've acquired the full arch impressions. So that was the Kettenbach material, the Panasil we talked about. We'll try in these wax try-ins to see what the teeth are going to look like, to confirm that the bite is accurate, and to get patient's approval. Since we got the patient's approval, we had the laboratory go to completion. These are monolithic zirconia restoration. There is some staining. I believe it's the myostaining that they use on the facial to create the gum tissue, but this is still, for the most part, monolithic. This is what it looks like in the mouth. So very natural looking. And then we'll go ahead and seal the holes with Teflon tape and composite once we've equilibrated the bite and make sure everything is ideal. And so here we see what we call a profile prosthesis, or an FP3. If you look carefully, you may see some of the access areas where we filled with composite. And this is in case we need to retrieve these at a cleaning appointment, or if there may be any issues, we can easily remove the composite, pop the Teflon out, and untorque these restorations. So when restoring these people with full mouth reconstruction or rehabilitation, we always try to go first molar to first molar occlusion. We don't try to go to second molar. Most studies indicate that first molar to first molar occlusion is more than enough. Here we have the final 2D image. Notice we've avoided the sinuses, but we've taken the implants as distal as possible. And so this is what we'll be talking about next weekend at our full mouth implant reconstruction course in Michigan. That course is already sold out. For those of you who want to sign up for our next course, we've opened a course in August 6 to 7. And so I'm sure Kurt will talk about that later this evening. Any questions?
You done?
Yep.
Yeah, let me
All set.
so let me turn it over to Kurt, as you mentioned. As I said at the beginning of the webinar, these webinars don't create themselves. It takes a lot of hard work, and we're thrilled to have Golden Dent be part of that ongoing sponsorship. They're also been kind enough that every time we do a webinar, they're going to make a special offer and also talk about some of the educational opportunities. So let's turn it over to Kurt, and we will get some questions after that.
All right, Lauren, I appreciate it. Just give me
your screen yet.
Just give me 1 second here. I apologize. I have a new computer here, and it's giving me a little issue here, so I apologize. Just bear with me here for a second. Do you want to, hey Laura, while I'm fiddling with this, I apologize. Maybe start going into the Q&A if you don't mind, and then we can come back to.
Sure, we could do that.
I have to do some security. Great. I have a new computer, and the GoToWebinar's giving me an issue here. I apologize. Just give me a second.
Okay. Okay, Ara. So you ready for some questions here?
Absolutely.
Okay, let's get to it. Now, some of the stuff you obviously went through during the some of these questions came in before you actually got into the webinar, but it never hurts to repeat some of it. Do you and how much do you charge for a first appointment?
So the first appointment, we're not charging for the consultation. However, we do charge for the scan. So if it's a full upper and lower scan, we're charging $275. If it's just one arch, then it's $150. And let's say somebody comes in, they think a tooth may be fractured, or they don't know why this tooth is bothering them, and we're just going to take a quadrant, then that's $90. So the CBCT actually will pay for itself very quickly, but in my personal view, I think it makes everyone a better clinician because you see a whole array of things that you never saw two-dimensionally. And now the prices
Right.
have gone down significantly on a lot of the CBCTs.
Other than the CBCT, what else are you doing during that complimentary first appointment?
So as mentioned, I'm doing the examination, I'm doing the clinical photos, and I'm talking to them. So I'm doing the consultation myself. After I've answered any clinical questions, then we'll have one of the treatment coordinators come in and talk about finances. So usually the patients may take advantage of some of the different payment options like Care Credit, Lending Club, Alphion's another one that's out there. We try to make this as affordable as possible. And so most patients can afford a payment plan. They can't afford to pay 25 or 50,000 all at once. So we offer different payment options to our patients to make this affordable.
Okay. Can a clear denture be used as a guide?
So in the past, before we had guided surgery, what we would instruct the laboratory to make would be a immediate denture and then make a duplicate clear denture of that immediate denture. And usually there would be a section that was troughed out so that the clinician would know where to place the implants. I haven't done it that way in about 12 years. With the amount of technology that we have, if you're not normally using a clear denture and this is your first attempt at full mouth reconstruction, I would highly recommend going with guided surgery as compared to having a window cut in a clear denture. Can you use it? The answer is yes. Do I recommend it? Only for those very highly skilled and trained clinicians.
Okay. I think Kurt might be ready now. Kurt, are you ready for me
Yeah,
to put it
I am
back on your
here.
screen?
Yeah, we can try it again. I apologize.
Okay, no problem. And then we'll get to some more questions afterwards.
Yeah, the joys of getting a new computer, I guess. So I appreciate everybody
Among
joining
many.
this evening. My name is Kurt Lawler with Golden Dent. We're a Detroit-based company. We're a third generational dental family. We've been in the dental education and product business since 2007, but before that we had been in dentistry for a couple other generations in being a dentist. And so we're, again, a Detroit-based company that operates under the principle of providing simple, predictable, and which focus on niche or unconventional products. So if you're new to Golden Dent, we appreciate your time this evening. So for joining the webinar this evening, we usually provide a promotional code, which is just a thank you for joining this evening. And if there's anything that piqued your interest, any of the products that were displayed by Dr. Nazarian through the techniques, we give you the opportunity to try those products and have a discount to do so. So it's 11% is what we're doing this evening. The code is GOLD11. So it's just GOLD and then the numeric 11. And you can learn more about the products that we discussed and our educational programs at golden-dent. So there's a hyphen there. .com, and then amplifieddental.com is our educational component of our product-based business. We do these deals for 24 hours. So we do them just kind of a quick special after the webinar. So it expires April 14th, which is tomorrow, end of the day. So physics forceps is kind of what started it for us with this aspect of our business about 12 years ago, 2007. This is still a really great and popular product. It's an atraumatic extraction system that was already explained in pretty good detail this evening through the cases shown by Dr. Nazarian. This is the most popular set. If you don't already have the physics forceps, the standard series is by far, like I said, the most popular and the easiest to use from a technique perspective. There's 3 upper instruments and 1 lower instrument. So there's a 1 lower universal, and then you have an upper right, upper left, and an upper anterior. And there's lots of videos and showing the technique and how they're used on our website. And they were already demonstrated on the webinar this evening. So this is what I would recommend if you ever have any interest in trying a more atraumatic extraction system, or maybe you're referring more extractions that you prefer. The system does work. You just have to remember it's not a forcep, it's really a lingual elevator, and just to use it lightly in your hands. You can use anything in advance, really. I guess a luxator and elevator. The one at the top is the one that Dr. Nazarian really likes, and a lot of our customers are using that. It's called the wedge. You'll find that on our website. It's a good pre-step to using the physics forceps. If you're more into the conventional type instrumentation, you know, that's great too. We did go ahead and make a really nice looking like 150, 151 and more of the conventional instruments, which you'll see on our site. We do have those available also in addition to the physics forceps. This is we use this more in our live patient programs. It's a complete graft kit. It's not expensive. It just keeps everything organized and together in a cassette. So when you are doing these grafting cases, you're not looking around for each individual instrument. It's just something nice to keep everything together and be organized for your grafting cases that you're doing. You'll see that on our site. It's less than, I think it's like $400 and some dollars. It's not too expensive, and it has all the basic instruments you really need for grafting. If you're looking for more like advanced instruments, we obviously have those also. These look like maybe more regular needle holders, but they each do have their own little unique aspect. One of the biggest things is a lot of the doctors really like this because they are snagless needle holders. You'll see there's no joints. A lot of them allow you to cut the suture with the needle holder. So if you click on any of these on our website, you can watch the videos and how they work. But these aren't these really are kind of niche or unique instruments, and each one has its own little kind of feature to be used. But these are really good needle holders. This is the kit we already showed on the webinar this evening. This is going to have your degranulation burrs and your bone leveling burrs, and it just keeps everything together in a nice burr block. We do have that available on the website. This is our allograft. So there's obviously a lot of allograft on the market. We've had great success with this one clinically. We tested it for years, and we've actually been selling it for a long time now. This is the one that Dr. Nazarian prefers, which is the cortical cancellous blend. So that's the only one we sell, and we have it in a putty in a particulate format. And if you're using a different allograft, we encourage you to give us a try. We like I said, we have fair prices and always have the product in stock, and it's a good quality product. The plugs, I don't think this wasn't really a program where we did more of the simple type grafts, but the osteogen plugs are still a very, very popular product for us. If you're just kind of getting into grafting, or even if you're just looking for a more simple graft that still has great clinical results, the osteogen plug is a synthetic bone graft and a collagen-based carrier. Comes in a couple different sizes. The large is the most popular. If you're not using this product, I would definitely look at it. It works really well for more like the single type cases, maybe not what we displayed this evening, but there's definitely a great use for this product in your practice if you haven't used it already. The EpiGuide on the left is the one that is our favorite, and the one that Dr. Nazarian uses in his practice. It's called the EpiGuide. It's a long-lasting resorbable synthetic membrane. It's kind of large. It's 18 by 30. So you can obviously cut the membrane to shape, but that's the one that we'd recommend. As long as it's a long-lasting membrane, I think you'll have good results. And this is one that we found provides good results. It's long-lasting and it's easy to handle. So sutures, PGA sutures, if you're using those, we have our own PGA brand. They're really affordable. I encourage you to look at what you're paying for your PGA sutures and compare them to our pricing. I think you'll be surprised. The quality is great on these, and then we also have our black silk sutures, which are very inexpensive as another suture option. Just want to mention this quickly because this just came out just a couple of days ago. This was a CR review on the pre-procedural rinse that we have. I know with COVID, this is an important step that a lot of offices are implementing, and this really is the one to use. There's all kinds of information on our website that proves that really this is the one that works. And this is the first study that they've done actually on actual, not in a laboratory, but actually on real patients with saliva, and they prove that it does actually kill COVID. And so if you look on our website, there's tons of documented studies, but it's by far the best one you can use for a pre-procedural rinse, and the studies definitely support that we have on our website. So I just wanted to mention that quickly. This is the course we got coming up already. It looks like next weekend that's sold out, but we do have our next date is August 6th and 7th. This is just a picture of the classroom that we use here in our office, and just some pictures of the hands-on program. So we do observe, wearing face masks and try to distance the group as much as possible during the day, and be mindful of the COVID restrictions that are in place. And we still have a great in-person class. So we've been doing these pretty successfully for the last number of months before we get back into our live patient programs this fall, which is great news. We took about a year off from our extraction, grafting, and immediate denture programs on live patients because there's hundreds of patients involved in the program, and we just couldn't make it happen with with COVID, obviously. But we have our first one coming up again in September, and then October, November, and December. These are actually live patient programs where you do the extractions, you do the grafting, and you do a lot of full arch cases like we displayed this evening. You're obviously not placing the implants, but you do extract all the teeth, level the bone, and do the grafting. So it's a great program, and we're finally starting those again this fall, finally, if everything goes as planned. This is just a picture of the program. There's Dr. Nazarian doing the first group demonstration before we break you out into your own operatory with a partner. And it truly is a hands-on program. So I'm looking forward to getting back to doing those here in September. I'll just mention one or two more things here before we turn it back over to the Q&A session, but we also are doing endo programs now here in our office. So our next one is June 11th. I just wanted to mention it. It's with Dr. Nazarian. It's called Endo for the GP. We did our first one, I think in the last couple of months. It was very successful. The program sold out. The feedback was great. So we're continuing to do these more classroom-based programs until we can get back into our live patient courses again. So if you can learn more about that on amplifydental.com, and the next one's June 11th. Here's a picture of the last program we did. You'll see obviously it's an endo course. We did everything just with models, but it was good. It was a great course. So June 11th is the next one. We have our own endo files, which are comparable to ProTaper, and a great woodpecker endo motor and pins and posts and all that product that you get to use in our course. Which we do have available now through Golden Dent. With that said, this will be my last slide. I wanted to just make a quick plug for anybody that's a regular joiner of our webinars. We found that based on the lack of trade shows, that a lot of our customers were asking us for more. It's not really in our wheelhouse because it's not niche type products, but people were asking for more inexpensive, basic surgical instruments. Whether it's curettes or needle holders or different types of instruments. We added about 250 instruments just about a month ago, and we've had pretty good success with that. I think that people that aren't going to trade shows are kind of looking for some of the stuff that maybe they haven't been able to buy recently at shows. So if you click that link there, I have circled at the bottom. Just take a look. I wanted to mention it because it's a little bit buried on our site, and it's something new for us. So take a look. They're good quality instruments, and they're very inexpensive. And that's it. I'll turn it back to Dr. Levine and Dr. Nazarian to finish the Q&A session, and I appreciate everybody joining this evening.
Kurt, for those live courses, is there a Zoom option? I know we got a couple of people that are on from Canada that were asking because the borders shut pretty tight, so I don't know if that was.
We were actually talking about that today. For the live patient program, the answer would be no for that. And we've historically actually had a lot of doctors from Canada join us. Hopefully the border will, open at some point. I know we're doing them in September, October, November, and December. I hope things are changed by then, but we are considering doing the endo for GP and then the 2-day implant classroom programs where we do allow people to join sort of remotely or through Zoom. That's something we're going to figure out here soon. So I guess I don't know the answer to that yet, but it's something we're definitely looking at. So I guess whoever's asking it, just try to keep in touch with us, or maybe we'll send an email out on it if that's something we decide to do in the future.
Okay. Yeah, it's wishful thinking. I mean, my whole family's in Ontario and they're in lockdown, so nothing soon. But that what you were talking about was a number of months off, so a lot can change. Great. Ara, you still there? You got time for a few more questions?
Absolutely.
Questions about the torque for the implants. You know, is there a certain number? Do you turn it back if it's say above 50? You know, how are you getting the torque?
So usually I found with the aggressively threaded implants, they're anywhere between 40 and 60 Newton centimeters. If we're torquing and they're going up to 80 or 90, obviously you don't want that much torque because you don't want to cause necrosis of the bone because of the increased pressure. But usually I'm staying within 40 to 60 Newton centimeters. The Adin implants do a great job of this. There's a lot of aggressively threaded implants that do it. Obviously, you don't want to underdrill the osteotomy too much. What I tell my doctors that I've taught in the past is if you're not even halfway down of positioning your implant and placing it into the osteotomy and it's already torquing at a very high level, back it out and increase the size of the osteotomy with the next size drill. Because you got to remember, bone is a living tissue. So if you crush it and put too much pressure, then sometimes the response may not be favorable.
Right. For sedation, are you typically putting them under, or you know, some deep IV sedation? Are you sometimes doing more like a nitrous, like a mild sedation? What do you
There are some
suggest?
patients that may just go with nitrous, but I would say 8 out of 10 times we'll either have an anesthesiologist or a CRNA that's putting the patient out. And so this way I can focus on the dentistry and they focus on the sedation.
Okay.
Obviously, we charge
Um,
for that too.
yeah, of course.
Yeah.
I think there was a case where you had done a 6 maxillary case, and the question was about had you considered ortho, because there was a fair amount of crowding and midline issues. I think there was another case that you showed as well. I think it was the last case where it didn't look like the midlines lined up. So was that something that was addressed down the road?
So if I'm understanding correctly, is it like doing ortho before so the extraction sockets are in the ideal position, or to do ortho on a non-restorable dentition? I'm not understanding the
Yeah.
question.
Yeah, I'm just reading them as I see them.
Uh-huh.
So the
Okay.
first question I'll quote it was consideration given to ortho treatment in the lower arch of the all on 6 maxillary case as part of a comprehensive treatment plan, lower crowding and midline issues?
I would say no, because the patient had a high caries rate, and by the time you were to try to straighten those, I think you'd be in a bigger dilemma.
Right. And then the other one was, thank you for a great presentation. Rudimentary question: why the last case the midlines did not match?
If you, the way the patient was biting, I think he was shifting a little bit. But again, when looking at midlines, depending on the position of where the implants are, if we want a midline that doesn't line up ideally, it's going to be the lower. So most patients won't know if a midline's off unless it's off more than 2 millimeters. But if for some reason we have to compensate for that, then it'll be in the lower arch where it's not noticeable. So the key is having the upper arch or the upper midline symmetrical and where the midline is right in the middle.
Okay. How is the Aiden implant superior to the OCO biomedical implant that you previously used? Does it also have a guided surgical kit available?
Yes, so the add-in implant is more threaded, number one, and most importantly, it has the osseo-fixed surface, which the OCO biomedical one did not. Both are very good implants. but I've transitioned to the Adine implant because they have more varieties of not only the sizes, but the support for digital type of dentistry.
Okay. And does it have a guided surgical kit?
Yes, absolutely. Fully
Okay.
guided, as we saw in the cases.
Okay. Any challenges in tying knots on the palatal mucosa? I mean, I assume there is.
I'm sorry, was there what?
The question was, how do you tie knots on the palatal mucosa?
How do you tie knots on the, well, so what I'm doing, maybe the picture that they saw is when I reflect a flap, I reflect the facial and also the palatal tissue. So when I reflect the palatal tissue, I will purposely suture it so that the flap is not extending into the surgical site, so that when I level the bone, I don't damage the tissue. So that's the reason why we'll tie it, but then we'll remove that suture, um, when we suture them together and put the flaps back. So
Yeah.
maybe that's
Okay.
where they saw the knots.
Yeah. Speaking about the flaps, for that lingual flap, what's your reference point? How do you know how deep to go with reflecting that flap?
Well, we're going as far as we need to seat the bone leveling guide. So if you feel like you can't position the guide and it's not seating, then you know you need to reflect a flap more. The one thing that I found is the reflector instrument works very well because it's a twist action using that thicker handle, more of like an elevator handle. But it's just, I guess, experience and training has shown me where I need to reflect to.
Hmm. Would you check ISQ before you put temporary cylinders?
If I'm getting good torque, um, I'm not really checking the ISQ until I'm ready to restore 4 months later, let's say, or if I'm going to restore earlier, let's say 2 months later. So I'm not always getting a ISQ at the very beginning. You can just to get a start recording of where you're at, but you have to remember the immediate fixation is a mechanical fixation. So the important number is after it's integrated and checking the ISQ at that point. But you can
Okay.
do it at the beginning if you prefer.
Okay. Do you have a favorite burr that you use to remove most of the bone during your bone leveling procedure?
Yeah, actually, I helped create the burr block for Golden Dent for the osseous contouring and shaping burr kit. So the burr that we have in that works very, very well. It's aggressive teeth on it, so it levels the bone very nicely, efficiently. The key thing to remember is to use adequate irrigation so you don't heat the bone up. But the burrs
Okay.
in that kit are actually the ones that I've came up with for Golden Dent. So it comes in a nice kit.
Okay. Is there a minimum length implant that you would use? I mean, I know there's a lot out there that are pretty darn short, but with your experience, what's usually the shortest you would go?
For a single unit or for these full arch,
Well,
I can
both, I
answer
guess.
both. How about that?
Yeah. Yeah. Let's do that.
For full arch, usually I'm not going shorter than 10 millimeters. My ideal length is 11 and a half or 13. Usually the most distal ones are 13 and the remaining implants are about 11 and a half. I try not to go with 10 if I can afford to not do that. For individual size molars, I've gone as short as 6s, but that's usually like a 5x6 or a 6x6. So again, our ideal thing is to achieve as much bone to implant contact. So if you can't gain that contact to bone in length, then you want to try and gain it in width. But
Okay.
very rarely am I using a short implant in these cases. And again, that's the whole reason of angling the implants, so we can get adequate length.
Sure. In the second case, which I can't remember exactly what case it was, the question was, how does the patient clean under the prosthesis?
So after we've seeded the restoration, even during their provisional time, we've instructed them how to use a floss threader, and most of them aren't going to use a floss threader. So we highly recommend investing in a water pick. That's another thing that we'll suggest. And then there's something called the shower floss. We're not affiliated with them whatsoever, but a patient had enlightened me about this product about 12 years ago. And it's like $30 or $40, and you can connect it to the shower. And it's got various tips for him and her to, irrigate the mouth so you're not using the same tip. But essentially, you're controlling it with your shower, and patients like it because it doesn't make a big mess as compared to, let's say, a water pick in front of the mirror.
Mm-hmm.
That's called shower
Let's see.
floss. People can look online for that.
Going back to that that first complimentary visit, how much time do you typically allocate for that appointment?
So that time is usually about a half hour of my time, but the appointment is an hour. So the time that I see them for that half hour is maybe 15 to 20 minutes. One of the things that I always instruct the doctors that are coming to the course is we as dentists sort of think as engineers, and so we start talking about millimeters and centimeters and leveling bone and all this stuff. And so most dentists will talk the patient out of treatment. So I tell doctors, keep it short and simple. Don't get too dramatic. Don't get too focused on the numbers. And let them know of the benefits and the value that they're going to achieve from this type of restoration, then ask if there's any other clinical questions. Usually identifying things on a CBCT, that 3D image sells the case, because people will see, exactly where I'm placing the implants, and it takes me literally just a couple minutes to plan it, illustrate to the patient, this is what I plan on doing, um, and it sort of sells itself. And usually 9 out of 10 patients will say, wow, I went for 2 other consults and the doctor didn't sit with me and they didn't go over this with me. It was, let's say, a treatment coordinator, or if it was the doctor, he just sort of said, well, I'll place like 4 to 6 implants. So I'll show them with the 3D image. It's not graphic to where they're going to be scared. But at the same token, it does educate them very well on what I'm going to do. And it illustrates that you're up to date with technology.
Okay. When you remove the prosthesis for routine maintenance, are you reinserting with new screws, or are you just using the existing screws?
I'm sorry, say that again.
When you remove a prosthesis for routine maintenance, do you reinsert with new screws, or are you using the existing ones?
It depends on how soon I'm doing it. If I'm just taking it off, let's say 6 months later or a year later, very rarely will I remove a screw. We'll inspect after we've cleaned the screws off in the ultrasonic to see if any threads may be distorted, and if necessary, we'll replace the screws at that time.
Okay. You had mentioned 3ddiagnostic.com, surgical planning and guide. Do you know what those cost approximately?
Depending on what you're getting, the costs will vary. So the surgical guide is a cost, the provisional is a cost. Some people may just go with the guide and not the provisional and just convert a denture themselves. So I think the best is probably to contact 3DDX for the pricing. But
Yeah.
let's say for an upper and lower, if you're going to be doing something like this, you're looking at about $2,400 in guides and provisionals.
Okay. I'm not sure if this might be a question more for Kurt. In the upcoming August course, which includes immediate dentures, is it hands-on and on patients?
No, the August program is going to be, what was discussed this evening, but obviously, much more detailed than 45 minutes or so. So it's a it's a full day lecture and then followed by basically a full day of lecture and then hands-on model work in the classroom. So it's not live patient for the August implant program, but then all the other ones, September through December, those are live patient programs where you actually do extract the teeth,
Level
do the
the
bone
bone,
leveling,
bases,
place the
yeah.
grafts, suturing, things like that. That's on patients, yes. And it's not just one patient. I mean, we'll have to see how it goes with COVID, but historically we've had 80 to 100 patients. I mean, is usually the way it works is you have as many patients as you can get through during the day. Usually you don't run out. We try to just kind of call it quits at 4 o'clock in the afternoon. So there's never a shortage of patients. So the Amplify AMP1, AMP2, and AMP3 programs are live patient, and then the endo and the implant program are classroom based on models.
Got it. Okay, great. A few more questions here. We want to get done, as I said, by the bottom of the hour. When you are diagnosing these patients, are you ever looking at the difference between CO and CR as part of that process?
Absolutely. We're going to look into all the occlusal aspects. So if you're doing any type of full mouth, whether it's on teeth or implants, it's important to know all the different occlusal schemes and make sure that we can reproduce that. And we go into that in the course. If we talked about that tonight, we'd be here for 2 hours.
Right. The question here was, I'm not sure specifically, minimum length of reduction needed for the teeth.
So when we look at reduction, and again, I go into this in detail in the course, we look at the transition line number one. Transition line is when somebody smiles really big, are they showing their gums or not? And if somebody has a real gummy smile, then if you don't level the bone, then the transition of the prosthesis to the gum tissue is going to be visible, and aesthetically it'll be a failure. So we look at the level that we need to reduce the bone so that you don't see that transition line of the restoration and the ridge. And so depending on the patient, depending on their smile, we'll look at that transition line. That's one of the ways we will calculate where we need to reduce. Another important factor is the restoration. So usually with an FP3 restoration, which again, we also go into detail at the course, there's just too much information. That's why we have 2 days for it. But essentially these restorations, you need about 14 millimeters clearance in order to be able to provide it, unless you're going to reinforce it with metal or something like that. So these are some of the different criteria that we look at when leveling the bone. We're not just going, okay, let's just level here to the socket or something like that. We're looking at the different levels, and this is what the doctors on the other end of 3DDX are going to inform you about, and other services that provide that, whether it's a laboratory or other centers that provide this type of planning, are going to look at that, and they're going to ask you to send them photos of the patient resting. They're also going to ask you to show photos of the patient smiling. Now, one of the key things to keep in mind is sometimes when patients are asked to smile, they'll only give a half smile. And so if you only level the bone to the half smile, and later once you've placed the implants and they do a full smile and the transition line is apparent, again, that's an aesthetic failure. So it's imperative to make sure that the patient smiles really big, almost gives you a forced smile to confirm that the level that we need to reduce to is the ideal level.
Yeah. Okay. Well, we're at the bottom of the hour. I had mentioned when we first started that I was apologizing ahead of time. We didn't get to all the questions. Normally for these webinars, we have more questions than we have time. And I did my best, and I do apologize if you had a question that we didn't get to, but I tried to combine a bunch of these together. As a quick housekeeping reminder, the webinar was recorded. That will go out sometime in the next couple of days, a link that you can watch it. The CE forms are sent out automatically by Golden Dent. It usually takes them a couple of weeks because we had, like I said, well over 800 people registered. So please be patient. There's nothing you need to do. When you log out after the webinar is over, you're not going to get a link to take a quiz or test or anything like that. It's all done automatically. If you were here, you're going to get it. If you came on for 5 minutes, you're not. But those should go out in the next week or two. So. Ara, anything you'd like to say before we wrap it up?
No, I just want to thank you for the opportunity to share this information with fellow dentists. I wish everyone a safe spring, and hopefully we'll see you in the summer or in the fall.
Well, we thank you, as always, for your continuing efforts here. I love your presentations. For those of you that have seen Dr. Nazarian in previous webinars, you probably hopefully noticed by now that you're not getting regurgitated slides over and over again. These are all mostly new cases, and we're always getting great new content, and we appreciate your time and expertise and passing that on to our colleagues this evening. Thanks again to Golden Dent for their continuing sponsorship of these webinars. I would certainly encourage you to take advantage of these specials. When they're a great company. We've got a lot of clients that use Golden Dent, and they've always raved about their products. They've got great return policies if by some chance you're not happy. But I would certainly take advantage of that special, the Gold 11, the 11% promo. And thanks to all of you. We know that all of your time is valuable, and hopefully you gain some new insight this evening. As most of you know, we do these webinars on a regular basis, usually at least around once a month with Golden Dent. So all of you who were here this evening will be sent an invitation for the next webinar as we have finalized the content and the speakers. So watch your inbox for that. Please stay safe and healthy out there, everyone, and we look forward to seeing you all on future webinars. Good night, everyone.